Thank you for providing this opportunity, madam. For the next 30 minutes, I am going to discuss about anticoagulation strategies in CRRT. So we know that AK is a frequent complication in critically ill patients, and it has its own broad spectrum of clinical manifestations. And if we see the underlying mechanism of AK, it includes a decrease in renal ability to excrete the nitrogenous waste products, manage electrolyte imbalance, and regulate body fluid homeostasis, and as well as acid-base status. So what is CRRT? Many of us know that it is a blood purification technique that uses the inherent principles of kidney function for achieving the solute and fluid homeostasis, and it is usually intended to be applied for 24 hours or even longer. So what does a CRRT require? A well-functioning access, a permeable membrane of filter, pumps to circulate blood and fluids, various solutions across the membrane with accurate fluid balancing, pressure monitoring systems, and anticoagulation. Before going to discuss about anticoagulation, we need to know about our therapeutic goals once we start CRRT. So the broad therapeutic goals are to maintain the fluid, electrolyte, and acid-base homeostasis, and we should prevent the kidney from further insults, and we should promote the healing and renal recovery, and we should promote the other supports like nutrition, antibiotics, and other organ support measures. The CRRT techniques usually differ in their operational characteristics to reach these goals. So why goals are important? Because there are multiple randomized controlled trials which has done for the last 3 decades has shown that there is a lot of disparity between the prescribed dose and delivered dose. So today morning if we start CRRT, by the next day if we see the patient and if we calculate the delivered dose, it will be definitely almost 20 to 30% lesser than the prescribed dose. So what are the consequences of this decreased circuit life? So as I said, it can leads to decreased difference between the prescribed dose and delivered dose, increased use of blood products, altered medical dosing, and the fluid removal from the patient will be inconsistent, and there will be a lot of setup manipulations. All these things can directly impact the patient health status, and also by doing multiple manipulations we may increase the cost of treatment in the form of giving more and more solutes, using multiple filters, and there will be a lot of expenditure for nursing time and pharmacy time. So what causes the short circuit life? So it can be broadly divided into 4 factors. It can be because of altered blood flow mechanics, and it can be related to the patient treatment related viscosity, patient related factors, and insufficient anticoagulation. If we see altered blood flow mechanics, it can be because of the vascular access dysfunction and circuit related factors, and it can be because of the increased treatment related factors, like if we give more and more blood transfusions, it may increase the filter clotting tendency, and if you give predominantly the replacement fluid in post filter modality, it may increase the filtration fraction and it can cause clotting of the filter. And patient related factors, like if the patient is in hypercoagulable state or if the patient is in hyperviscous state, that may cause short circuit life. And finally, coming to my topic, insufficient anticoagulation. If you don't provide effective anticoagulation to the circuit will be prone to get clotted very early. So what is anticoagulation in CRRT? So as in many other extracorporeal circuits, anticoagulation is essential to prevent clot formation in the circuit and to maintain effective clearance also. So the choice of anticoagulation depends upon these important factors like access site, the type of membrane that what we are using, and the modality of the replacement fluid, whether we are giving in pre-filter form, pre-filter or post-filter, and the coagulation status of the patient. So what is an ideal anticoagulant? So ideal anticoagulant is the one that should have an optimal antithrombic activity, minimal bleeding risk, short half-life, and there should be a reversible agent if some bleeding happens, and it should be inexpensive. So coming to the anticoagulation options in CRRT, so we can run a CRRT without any anticoagulation just by giving saline flushes, and we can run the circuit by giving regional anticoagulation in the form of regional citrate anticoagulation and heparin with protamine reversal. And there are multiple systemic anticoagulants like unfraction heparin, low molecular weight heparin, platelet inhibiting agents, thrombin agent inhibitors, heparinoids, and sometimes we may need to provide systemic anticoagulation along with regional anticoagulation. Like if the patient is on ECMO, we may need to run the ECMO with the systemic anticoagulation, and we may need to run CRRT with the regional anticoagulation. So these are the list of the conventional anticoagulation methods that can be used. But today I'm going to discuss about the routine available drugs that what we commonly have in our hospital scenarios. So first, coming to the unfractionated heparin. So it is a large pentasaccharide molecule which will be available from 5 kilodaltons to 30 kilodaltons. So because its structure is large, when it gets binded to antithrombin, it potentiates the effect of antithrombin on factor 10A and factor 2. So when it is bounded to the antithrombin, it creates a small change in the loop of antithrombin so that it can be bound easily to the target agents. So because it has the capacity to bound to and factor 10A and thrombin, the anti-factor 10A and anti-factor 2A capacity to inhibit both the coagulation factors is almost equal for heparin. And heparin causes the release of tissue factor pathway inhibitors from the endothelium, which may contribute to antithrombic activity also. If we see the half-life of heparin, it is almost equal to 90 minutes, and it may be increased in renal failure for multiple reasons. So what are the limitations of heparin? See, if you give heparin, the first limitation is it has a very poor bioavailability at a low dose. If you give small amount of heparin to anyone, so first initially it will be binded to all the endothelial cells and macrophages, and it will be not available for effective anticoagulation. And suppose if you give lot of heparin for someone, as I said, initially all the heparin which is being given to the patient will be bound to the endothelial cells, and remaining will be available for anticoagulation. So one of the limitation is poor bioavailability at the low dose, and it has a dose dependent clearance. And there is also one of the the other limitation is variable anticoagulant response, because if you give heparin to anyone, it has the capacity to bind to plasma proteins and acute phase reactants. These acute phase reactants are very high in patients suffering from sepsis or CIRS like severe inflammation, and patients suffering from chronic kidney disease. They have multiple anti-inflammatory substances and acute phase reactants. This heparin will be bound to them, and it cannot show its activity. And also, if the heparin has less activity in the vicinity of platelet-rich thrombi, because the activated platelets releases the platelet factor 4, it will make the heparin ineffective. So coming to the unfractionated heparin protocol, it is quite simple. Many of us know we will be giving heparin before the filter, and we will try to maintain the circulation without any clotting. As I said, if you give a low dose of heparin, it will be bound to all the endothelial cells. So we may need to give a bolus of heparin, and then we may need to give continuous infusion. And we need to monitor APTT and try to keep it 1.5 to 2 times the upper limit of normal for the time of treatment. Not only APTT, there are some other protocols where we can give heparin anticoagulation by monitoring INR and platelet count also. So this is the sum of the one study. It has shown that if you can maintain the INR will be less than 1.5, you can give heparin like normal infusion, 10 international units per kg per hour. And if the INR is going more high, like more than 2.5, preferably you can avoid anticoagulation. And if the platelet count is more than 1.5 lakh, you can give normal heparin infusion. And if the platelet count is getting down, we may need to stop anticoagulation with low molecular weight heparin. So coming to the advantages and disadvantages of heparin, we know that unfractionated heparin is quite effective, widely available. It can be monitored easily by APTT. It can be reversed with protamine. It is inexpensive, and it has a short half-life. The disadvantages are it has a systemic bleeding tendency, and as I said, there is unpredictable pharmacokinetics, and APTT is not a completely reliable marker, and it has less resistance in patients with less antithrombin levels in the body. Like if the patient is suffering from nephrotic syndrome, they may have very low antithrombin levels, and the heparin may not show its quite effect in this group of patients. And a well-known complication of heparin, we know that it can cause heparin-induced thrombocytopenia. Well, next, moving on to the regional anticoagulation with the help of protamine, we can give heparin before the circuit, and we can infuse protamine after the circuit, and we can keep the circuit in such a way that it will be not clotted. So by this method, we can make the regional anticoagulation. We can give heparin 100 units, and the protamine that is required is to neutralize that heparin is almost 1 milligram. So if you are giving unfractionated heparin 1000 to 1500 units per hour, you may need to give protamine 10 to 12 milligrams per hour. It has its own advantages and disadvantages. Yes, the main advantage is anticoagulation effect is restricted to extracorporeal circuit. Disadvantages are hypotension can be caused by protamine, and it also causes hypersensitivity, and we are not sure what happens to this heparin and protamine complex once it is entered into the patient circulation, because this protamine can show some rebound effect, because it can inhibit the effect of factor 5, and there will be increased bleeding tendency also. Coming to the next common molecule, low molecular weight heparin. It has a molecular weight of almost 5 kilodaltons, and its half-life is 2 to 4 hours. Yes, its half-life is increased in renal failure, and also patients with suffering from morbid obesity and pregnancy group of people can have long effect of low molecular weight heparin. Because its structure is little bit short, it has the capacity to bind with factor 10A easily, but its effect on factor 2A is less. So it's the effect, if you see the low molecular weight heparin capacity to bind anti-factor 10A and 2A, it will be from 2:1 to 4:1. So what are the protocols of this low molecular weight heparin? Yes, we can give it as a fixed dose, or we can give it as a maintenance dose. If you want to give based as a maintenance dose, you may need to monitor anti-factor 10A level, and it should be maintained between 0.25 to 0.35 units per ml. And these are the routine molecules, enoxaparin, and every one of us know, and dalteparin. The data shows that the mean filter life with enoxaparin is almost 30 hours, and with the dalteparin it is variable. However, it has been documented that the filter life has been prolonged to 50 hours also. So coming to the advantages and disadvantages. Advantages, we know it is quite effective, and it has predictable pharmacokinetics, lower incidence of heparin-induced thrombocytopenia, less effect on lipids. But there has some disadvantages like systemic bleeding, and it is only partially reversed with protamine. And if you want to give as a maintenance dose, the anti-factor 10A activity monitoring level will not be available routinely in many of our hospitals. And if you want to use low molecular weight heparin, it is quite expensive when compared to unfractionated heparin. Coming to the next group of drugs, heparinoids. This is the there is only a small data regarding the use of heparinoids in CRRT, but it is worthwhile discussing a few short time about these group of drugs. We know that we have two molecules, danaperoid and fondaparinix. They come as a mixture of heparin, dermaton, and chondroitin sulfate. They predominantly affect factor 10A, so they can be monitored by anti-factor 10A assays, and their half-life is prolonged in renal failure. But there is some small data that danaperoid may cross-react with HIT antibodies in 10% of cases. So it may not be a great drug of choice if patient develops heparin-induced thrombocytopenia. So coming to the fondaparinix, it does not react with HIT antibodies, and it has an extended half-life. So if the patient has heparin-induced thrombocytopenia, fondaparinix can be given. And if we want to give for a CRRT, we may need to give as a pre-dialysis dose of 2.5 to 5 milligrams, and aim to maintain anti-factor 10A level less than or equal to 0.2 international units per ml. Though there is no specific antidote for if there is any bleeding occurs with the heparinoids, there is some data that recombinant factor 7 can be given if the patient develops bleeding with these group of anticoagulants, but large studies are needed in this area. Coming to direct thrombin inhibitors, the drugs that are being commonly used and studied in CRRT are lepiridine, argatroban. But after 5 days of lepiridine use, patient may develop anti-lepiridine antibodies, and contrary to our expectations, these are the antibodies that can potentiate the bleeding tendency rather than decreasing the bleeding tendency, and we may need to give FFP to reverse the bleeding if it occurs because of the overusage of these drugs. This cartoon shows it's a comparison between argatroban and lepiridine. Argatroban has a half-life of almost 40 to 50 minutes, lepiridine around 1.2 hours, and argatroban predominantly eliminated by hepatic route and lepiridine by renal route. And if you want to monitor, we need to monitor APTT for both these group of drugs. Yes, there is some amount of bleeding risk, and there is no antidote available, and as I said, if there is any bleeding, we may need to give FFPs. And these are the new molecules, prostanoids, prostacyclin and its analog epoprostenol are potential antiplatelet agents that can block cyclic AMP. Because they can block cyclic AMP, they may cause some hypotension to the patient, and it has an advantage of using as a regional anticoagulation because its half-life is very short, and at the same time, because it has a very short half-life, if the patient develops hypotension, we can reverse it by just stopping the infusion. And this is the newer promising molecule which is being currently used as a default anticoagulation method in Korea and Japan, and it's a serine protease inhibitor. It inhibits multiple coagulation factors including thrombin, 10A and 12A. It can be given as a continuous intravenous infusion, and we may need to monitor APTT and try to keep it more than 2 times the upper limit of normal. And it has a half-life of only 8 minutes, so it has if there is any bleeding tendency or if there are any anaphylaxis chances, we can just stop the drug and reverse the effect of it. And there are documented what are the documented side effects with this drug is anaphylaxis, agranulocytosis and hyperkalemia. So why we need to discuss about all these anticoagulants is what KDIGO recommends is if the patient condition is sick and if you have chosen CRRT as a renal replacement therapy modality, KDIGO strongly recommends to use regional citrate anticoagulation. And if the patient condition is such a way that if we cannot use regional citrate anticoagulation, then go with heparin, and if there is any bleeding risk, then only proceed with anticoagulation. So by this recommendation, what we can understand is we need to always maintain the circuit with some kind of anticoagulation, and if there are no contraindications at this point of time, KDIGO recommends to use regional citrate anticoagulation. So we need to understand more about regional citrate anticoagulation based on these recommendations. So why citrate rather than heparin? So there are almost 13 randomized controlled trials done in around 1500 to 1600 patients, and they have documented that there is statistically significant less circuit loss with the use of citrate and statistically significant less bleeding risk with citrate, and there is no difference in mortality and no difference in metabolic alkalosis by the use of citrate when compared with the heparin. So how this works? So we know that the coagulation intrinsic pathway and extrinsic pathway, calcium is a very important clotting factor required for effective clotting coagulation cascade, and citrate, if we give, it will be binded to this calcium and it will make the calcium unavailable to participate in coagulation cascade. Regional citrate anticoagulation we need to discuss. So citrate is a small negatively charged molecule with a molecular weight of almost 190 Daltons, which is very, very small. So studies have shown better filter life, less bleeding risk in varied group of population in sepsis, liver failure, cardiac surgery, and both pediatric and adult group. Why I have kept liver in orange mark is I am not confident in using citrate in patient with significant hepatic failure. That why I am going to discuss in my next few slides. Coming to the principle of citrate anticoagulation, this is the basic principle. Normally the blood contains 0.05 millimoles of citrate, and there are multiple studies have documented that if the blood citrate level is increased to 3 to 5 millimoles per liter, or if you can decrease the ionized calcium to less than 0.35 millimoles per liter, the bleeding time will be infinity. So based on this principle, the first citrate anticoagulation was started. The principle is simple. As I said, if we give citrate, it will be bound to the ionized calcium in the circuit, and it will make the calcium unavailable for anticoagulation. So what happens to the citrate once it gets into the body? So if we see systemic citrate clearance, citric acid has a very short half-life of 5 minutes, and it will be, once it enters into the body, it will be rapidly metabolized by the liver, kidney and skeletal muscles. So during metabolization, one molecule of citrate can generate 3 molecules of sodium bicarbonate. So this can be used as a buffering agent in acid-base imbalance also. In the coming to extracorporeal citrate clearance, as I said, it has a very low molecular weight, so clearance will be little bit almost equal to the urea, and the sieving coefficient between 0.87 to 1, so that it can be easily passed through the filter. And because we are giving predominantly regional citrate anticoagulation in the pre-filter mode, the clearance will be equal in CVVH and CVVHD. And as like any other molecules, the clearance depends upon the concentration and the filtration fraction. and like any other molecules with a very significant sieving coefficient, almost 40 to 60% of the citrate will be cleared from the circuit. So coming to the advantages and disadvantages, the advantages are it is regional and it avoids bleeding complications. We are not very sure about this statement. It doubles as a buffer, but definitely it contributes to some metabolic alkalosis in such a way that what 1 molecule of citrate, 3 molecules of bicarbonate will be generated. And yes, it is very highly effective than heparin, and definitely it doesn't cause thrombocytopenia. Coming to the disadvantages, the important disadvantages are metabolic complications and complex protocols involved in the citrate anticoagulation. So if you want to give citrate to any patient, we can give we can deliver it as a fixed dose, or we can deliver it based upon the ionized post-filter ionized calcium. If you want to give it as a fixed dose and if you want to feel comfortable during the therapy, you can just keep the CRRT machine in the citrate mode and give the blood flow of 100, so that the machine will automatically deliver residuocit, that what we routinely use in 1000 ml per hour as a pre-filter. Why this is important? Because if you are giving as a fixed delivered dose based upon the blood flow, the machine will automatically increase the residuocit flow. And it has been documented that if you can give residuocit at 1000 ml per hour, it will be almost equal to 3 millimoles per liter of the citrate in the blood, and it can effectively anticoagulate the blood. So coming to the citrate solutions, from almost last 3 decades, there is a lot of change. We can discuss it in the next few slides, but it is worthwhile to notice that there is a change in the sodium concentration in the citrate. Like initially it was 408, now it is 140, almost isotonic. And citrate levels, which is very high in the initially almost 38, now it is 0 citric acid. And sodium citrate, which was 106, we decreased it to 18. Why these changes are happening and why it is important, that I am going to discuss now. And before going to discuss those aspects, we need to know about the bags that we use for citrate. These are the available bags, multiple bags in all over the world, but in India we are using as of now Residuocit, which is from the Baxter, that we are also using it in our hospital. Coming to the other bags, this Residuocit is a replacement solution which is given in the pre-blood pump as an anticoagulant, and as a dialysate we use bifossil. It is a calcium free and phosphate containing. This dialysate solution bifossil can also be given as a post-filter replacement fluid if you want to increase the effluent dose. So these are the bags that what we use for regional citrate anticoagulation, Residuocit, and we need to notice about the components after complete reconstitution. It has 18 millimoles of citrate, sodium is 140, which is isotonic, and chloride is less, 86, and the dialysate fluid and post-filter replacement fluid is a bifossil. It also contains sodium of 140, which is isotonic, and it has a potassium of 4, so that we can relax if we are giving this as an replacement fluid or dialysate, because we need not to monitor potassium much frequently in any group of the patients, because it will maintain at 4 serum potassium. And the other constituents are hydrogen phosphate and hydrogen carbonate, and it has an osmolality of 290 milliosmoles per liter, which is almost isotonic. So coming to the protocols of citrate protocols, there are multiple protocols all over the world, but the principle is same. We may need to use citrate before the filter. It binds to the calcium in the filter and it makes it unavailable for anticoagulation. This is our renal clinical services protocol, that what we are using in our hospital. We give pre-filter fluid or pre-filter replacement fluid Residuocit. It contains sodium chloride and sodium citrate. It is given before the filter, and we will give dialysate as a bifossil. It will be given away from the filter, and we may need to give calcium supplementation by a separate venous line, or we may give just by adding a three-way connector to the venous limb, and we may need to infuse calcium gluconate there. And we may need to be aware of all these mechanisms, because once again I am telling, we will be giving Residuocit in the pre-filter mode, and the dialysate will be going in the dialysate limb, and we will monitor post-filter ionized calcium and pre-filter ionized calcium. The post-filter ionized calcium will be monitored by a VBG. Pre-filter ionized calcium will be monitored in the form of ABG. So how we work with citrate? We use Prismaflex machine, and the set will be M100, but if the patient is a body weight is low, we may go with M60, and we have done citrate with HF20 with a infant also. So If we need to prime with saline, we will keep the default blood flow as 100, and we will keep the dialysate flow based upon the target effluent dose divided into weight divided by 2. Suppose if the patient body weight is 70 kgs, if we want to calculate an effective dose, we always keep CRRT in such a way that we will deliver 30 ml per kg per hour as a overall effluent dose, and if you multiply by with 70, it will be coming in and around 2000. So we have to half it, in the sense dialysate flow will become 1000, and remaining will be pre-blood pump. So it has an advantage because, as I said, if you keep the pre-blood pump or citrate flow in almost 1000 ml per hour, it will be almost equal to the citrate concentration of 3 millimoles per liter, which can effectively anticoagulate the blood in the circuit. So coming to the post filter replacement, if it is an optional, initially as a default prescription, we won't use regularly post filter replacement fluid, but if the condition demands, we can use post filter replacement fluid, and the fluid that what we use is a bifossil. And ultrafiltration, it will be based upon the patient clinical status. We will remove it as per the requirement. And as I said, we may need to give calcium gluconate at the venous end of the circuit. Guidelines say to start with 0.25 to 0.5 ml per kg of body weight, but what we regularly use is we see the ABG before starting CRRT, and if the baseline calcium is very low, I would keep the calcium infusion as 20 ml per hour, and if the baseline calcium is in and around 1.1 or 1.2, I will keep the calcium infusion at 10 ml per hour, and I will change it based upon the requirement in next subsequent couple of hours. So these are the normal ranges. We may need to keep the post filter ionized calcium with 0.25 to 0.35, and systemic ionized calcium between 0.9 to 1.1. Transmembrane pressure, preferably keep it less than 150, and try to see and achieve sieving coefficient of less than 0.7, and ensure that the citrate accumulation index is less than 2.5. So the laboratory checks, as I said, for every second hourly for the first 8 hours, I will check the post filter ionized calcium in the form of VBG and systemic ionized calcium in the form of ABG, and daily we will check CBP, creatinine, blood urea, serum electrolytes, so total calcium phosphorus and serum albumin, and bag urea. And cumulative fluid balance to be done definitely at the early morning at 6 o'clock, and do not forget to check the sieving coefficient daily at 6 a.m. And if you suspect any excess recirculation, in the sense if you are giving calcium through a venous limb of the CRRT circuit, sometimes all this calcium will be going only into the circuit rather than going into the patient, and you may see persistently ABG showing very low ionized calcium. If you are in that situation, preferably take a secure a Venflon catheter well away from the dialysis access circuit and give calcium infusion through that circuit. The other formula that what I was discussing, sieving coefficient, it will be almost like the blag urea divided by blood urea, and we may need to keep this beyond more than 0.7. Citrate accumulation index, it is a very important tool. We may need to monitor daily morning if someone is on citrate anticoagulation. It is total calcium into 0.25 divided by systemic ionized calcium. And urea removal. Urea removal means whether we have reached the what is the difference between the prescribed dose and delivered dose. We may need to target that we should be almost 80 to 90% of the prescribed dose. This is equal to sieving coefficient into effluent dose, that what we are giving. Troubleshooting, yes, as I said, calcium infusion will be based upon the systemic ionized calcium. Systemic ionized calcium means ABG. So if the ABG is showing low calcium, we may need to increase the calcium infusion, and if the ABG is showing more calcium, we may need to decrease the calcium infusion. Citrate infusion will be dependent on the post filter ionized calcium. So immediately if the after coming from the circuit, we take a sample and send for blood gas analysis and see for ionized calcium in that. So if the ionized calcium in the post filter sample, I am repeating it many times, post filter sample or VBG, if the calcium is very low, that means we are giving more and more citrate. If the calcium is going high, that means that citrate infusion is less for anticoagulation. So systemic ionized calcium determines our calcium infusion rate. Post filter ionized calcium determines our citrate infusion rate, and the changes are preferably not beyond 10% of the previous value. That is called as rule of 10%. And we may, if the systemic ionized calcium is very low, that means if it is going below less than 0.8, we may need to give calcium bolus, because if the systemic ionized calcium is getting very low, the patient will bleed sometimes. So as I said, rule of 10, every change should be made in 10% value only. Suppose this is an example. The calcium gluconate flow rate previously if we have set as 20 ml per hour, if the systemic ionizer calcium is going high, reduce it only by 10%, like keep it at 18. If the systemic ionizer calcium is low, if you want to increase ionizer calcium, keep it at 22. So this is called rule of 10. We may need to keep everything in that 10% changes only. Coming to the liver dysfunction, so if the patient have significant liver dysfunction, as I said, the citrate will be metabolized predominantly in the liver, kidney and skeletal muscle. The fact that if the patient is on CRRT, we take it for granted that the citrate metabolism definitely will not be occurring in the kidney, and we depend on liver for conversion of citrate to bicarbonate. So if the liver is not functioning well, the patient will have more and more citrate in his blood, and citrate will be accumulated. So in this scenario, what we do is we will just take a decision that whether we may need to continue citrate or without any citrate. Suppose if the liver function is subnormal and if the citrate accumulation index is not going beyond 2.5, we can give citrate anticoagulation, but we may need to decrease the pre-blood pump citrate rate. But what happens is, if you decrease the pre-blood pump citrate, the overall effluent dose will be decreased, so we cannot compromise on the overall effluent dose. So what we should do is we will give post filter replacement fluid in the form of bifossil. So in any form of CRRT, there should be no compromise in the effluent dose. So coming to the pros and cons of this monitoring anticoagulation of citrate, suppose if we are giving citrate in a fixed form, in the sense if we keep the machine in fixed modality like in citrate mode, if we keep the blood flow at one particular level and the machine will give citrate in that particular requirement. With this, the pros are definitely we can relax, there is no need to monitor much frequently, and the buffer supply to the patient will also be significant. But we are not sure about the anticoagulation because we are not monitoring the ionized calcium, what is going to happen in the post filter. Suppose if we deliver citrate based upon the post filter ionized calcium, the pros are, yes, if we are targeting 0.25 to 0.35, definitely there will be a significant anticoagulation. Monitoring cons are, we may need to monitor post filter ionized calcium every second hourly for the first 8 hours, and we need to adjust the citrate based upon the requirement also. What we are doing in our unit is we will monitor post filter ionized calcium because we will we want predominantly we need to target anticoagulation, so that's why we will monitor post filter ionized calcium and change the citrate based upon the requirement. So the metabolic consequences are, yes, it can cause metabolic alkalosis because if too much citrate is going into the patient with a well functioning liver, all the citrate will be converted to the bicarbonate, and this will contribute to some amount of metabolic alkalosis. Coming to the metabolic acidosis part, if the patient is having liver disease and if the patient is having very severe bad shock, the citrate cannot be converted to the bicarbonate and it will be accumulated in the blood, and what it do is it causes high anion gap metabolic acidosis. And hypernatremia, which is not common now because the dialysate solution and rigocid that what we are using now are isotonic with 140 sodium level, so we are not seeing this complication in routinely hypernatremia. Hypocalcemia and hypercalcemia, these are known because we are entirely dealing with the calcium levels in the body. We may get into the situation of hypocalcemia or hypercalcemia, but with proper monitoring in the first 8 hours, definitely we will reach a stable level of calcium infusion and citrate infusion, and we can avoid this complication. And lastly, hypomagnesemia. Yes, citrate has the capacity to bind with magnesium in the blood circulation, so some people may develop hypomagnesemia. And this, as we know that regularly if someone is on CRRT, the next day morning we will always check blood urea, bag urea, calcium, phosphorus and magnesium routinely, and if the patient is having hypomagnesemia, we may need to address it by giving magnesium sulfate infusions. So coming to citrate accumulation and toxicity, the risk factors are persistent shock. Suppose if the patient is having severe cardiogenic shock or septic shock, the perfusion to the important organs like liver and skeletal muscles will be low, so the citrate will be accumulated in the body. And if there is significant lactic acidosis, or if the patient is having severe liver failure, and if the patient is suffering from any mitochondrial disorders, the chance of citrate getting accumulated will be very high. So and how we detect is, if there is any worsening metabolic acidosis, or if there is an elevated total calcium, and if there is any decreased ionized calcium, then we can be alarmed in such a way that the patient is going into citrate toxicity, and we may need to address it immediately. And this shows the importance of the calcium gap. This is a normal person, and this is a patient with citrate based CRRT. If you see overall calcium, it will be almost similar in both the group of patients, but if you see the exact type of calcium that is there in the citrate group of patients, the ionized calcium will be decreasing, the protein bound calcium will be similar, and there will be high levels of calcium citrate complex in this group of patients. Why it is important is, this calcium citrate is dangerous because the calcium in the calcium citrate complex is not available for any anticoagulation, though the patient may have any bleed, that is the most dangerous complication, and at the same time the citrate can contribute to the metabolic acidosis continuously if you are giving it frequently. So what is evolving in regional citrate anticoagulation? We will need to see the strength of citrate solution, mode of delivery to the CRRT circuit, and the number of bags that we are using to perform citrate based CRRT, and the dialysate and fluid compositions. So if you see, initially 3 decades ago there were almost 5 bags. Initially one bag will be containing calcium, the other bag will be containing citrate, the other will be dialysate and pre-filter, post-filter. Almost 5 bags will be hanging in and around the machine, and now it has decreased to 4, and now currently we are having only 3 infusions. One is citrate, one is calcium infusion, one is dialysate bag. So we have moved from 5 bags to 3 bags, and previously there was chance of developing hyponatremias because of the dialysate sodium during the initial bags are only 117. Now we have moved to 140, so that there is we are maintaining appropriate sodium for that patients. And the citrate load also, sodium citrate also, initially it was 408, and by decreasing the citrate level we will be able to achieve 140 millimoles per liter of sodium citrate. And citrate concentration initially in 3 decades ago it was 140, and we moved to 18. So why this is important? Because if the citrate concentration is very high, we may need to decrease the citrate flow rate. If the citrate concentration is low, we can increase the flow rate. So by decreasing citrate concentration and by increasing the flow, we will be achieving the target effluent dose easily. And because we are targeting proper citrate levels in the blood, the circuit life was also prolonged from 50% to almost 86% based upon the bags that we use. So I'm little bit hesitant to share this, but we will definitely reach this stage like only 2 bags. The first bag containing citrate containing solution like what we are using now, and we may get a replacement fluid which contains a calcium, so that this replacement fluid will be directly delivered to the patient, and there will be no need to monitor frequently the levels also. So lastly, coming to the conclusions and suggestions, yes, anticoagulation is definitely required for optimal function of CRRT, and the best options as per KDIGO, they recommend regional citrate anticoagulation, but now we may reach in the next couple of years that nafamostat is a promising molecule which is almost equal to regocit citrate based anticoagulation, and definitely both of them are much more superior to heparin. But if you do not give any anticoagulation, it may decrease the filter life, and it will decrease the delivered dose also. So what is the next question is, what is best in Indian scenario? Based upon the clinical status of the patient, we can use heparin, but if we are having in a proper setup where our technicians or everyone are trained, it's always better to go with citrate. And coming to the hybrid methods, sometimes the patient comes in such a situation like evening 8 o'clock patient comes to the hospital, his noradrenaline requirement will be 5 ml somewhere, we want to start CRRT, but as previous my teacher said, before taking the clearance from all the departments, financial clearance, patient attendance clearance, we may reach in around 2 o'clock in the morning. At that point of time, the noradrenaline goes to 15 ml, 20 ml, and we consultants, we also feel little bit shy to start citrate because we know that the patient is in severe shock, and we may not be able to convert the citrate to bicarbonate because we are dependent on the patient circulation, hemodynamic status, and liver, well functioning liver to have a proper buffering agent. So what I will do is, if in this scenario, I will start now without any anticoagulation at midnight, 2 o'clock, because I cannot take calls every day, and at the same time, only one technician will be available at the night time. So he will be hesitant to start citrate anticoagulation because they are not aware about the patient clinical status. So I will buy some 6 hours or 7 hours time. By the time 8 o'clock I reach hospital, I will run the circuit without any anticoagulation. And once I reach hospital with the same filter, just I change the bags from normal Prismaflex bags to citrate bags and run the circuit. So what is required for best outcomes in this citrate based CRRT or overall CRRT? It is a teamwork. And without one person cannot definitely make a great change in any anticoagulation or citrate in a very critically ill patients. We need a teamwork. So if you see, this is a very interesting, many of us are aware about this picture. Here you can see the president sitting in the corner allowing the army director to perform his own job. In a similar way, we sit as in our department, we work as a team. My boss will be always pushing us to do our work, and he will never interfere in work. He'll only ensure that all of us are working together to make the department and citrate or whatever the critically ill patients to have a better treatment. Thank you.
So excellent talk, Dr. Mahesh. So what is your experience on using regional citrate for those who developed heparin thrombocytopenia due to heparin?
So it is always better option if someone develops heparin-induced thrombocytopenia, sir, because we may need to keep the patient in a state like he should receive proper anticoagulation. If you do not give any anticoagulation, the circuit will be clotted. So whatever the case scenarios that I have came across is based upon your question. Heparin-induced thrombocytopenia happened in one of the patient who is on CRRT, but we are not using heparin for maintaining the circuit. The patient is receiving heparin as a part of DVT prophylaxis, but after a couple of days the platelet count was getting down. Patient clinical condition was okay, but we have sent an HAT antibodies. It was positive, and we may need to give other anticoagulant. But because the platelet count is very low, our critical care team asked to give fondaparinux, so we are giving fondaparinux for that patient. But at the same time, it will be not a great drug to keep the circuit patent, so I have used citrate in that patient. So one side I have used fondaparinux as a treatment for heparin-induced thrombocytopenia, and to keep the patent circuit I have used citrate anticoagulation. And whatever the experience I got till now, if you ask me what is your filter life, I can say infinity, because none of the patient who are on citrate based anticoagulation, the set was not clotted. Either patient has recovered, the patient has died, that is only happened, but circuit was not clotted at any point of time. But we came across one situation where initially I have started on citrate, but the patient clinical condition was little bit worsening, and the acidosis is going increasing, and the total calcium citrate infusion level is very high. I mean, the citrate accumulation was 2.6 for that patient. I moved from citrate to without any anticoagulation, because the platelet count was also very low for that patient. I changed it from citrate to without anticoagulation mode. Ultimately that patient did not do well, but there is a possibility that we can switch from one mode to other mode, in the sense we can start without any anticoagulation and shift to heparin, and then if you want we can move it to citrate, and the otherwise is also can be done. We can start with citrate and we can convert it to without any anticoagulation.
So many centers actually, because of this cumbersome citrate protocols,
yes sir,
I think they're still using heparin based anticoagulation.
Yes sir, as I said, it's not in many centers. We also in the initial part of this, though we know about the protocol well, we are unable to start because we have a lot of inertia about the patient health status, and we are very sure that the patient is having very significant shock whether the citrate is going to work or not. That's why what I will do is I will buy some time by doing without any anticoagulation, and once the shock improves, and if I am sure that the technicians in and around the scenario are very well educated, and if I am confident about the technicians, then I will change it to citrate.
So what is your take on direct thrombin inhibitors? Have you had any
No madam, direct
opportunity to
thrombin
use?
inhibitors I have less experience. It is only whatever the data that I have showed is based upon the trials and textbook data. I don't have a good experience in direct thrombin inhibitors, but I think, see, we may need to and give some, the main purpose of the citrate based anticoagulation is, it is a regional. So if we always want to avoid systemic bleeding complications, and at the same time we may need to prolong the circuit life so that the patient health will be definitely better. So I would always feel that rather than using some drug which has a systemic anticoagulation, prefer some drug which has a local anticoagulation. If someone asks me what is the best option, I would go for citrate. And this year, PAC 2023, we went to Korea, and we have seen lot of data in Korea regarding the use of nafamostat. So they also say that nafamostat is very better regional anticoagulant because its half-life is very short. So by the time it enters into the circulation, the effect will be very, very minimal. So they can maintain the circuit pattern just by giving it before the filter. So that's why I said citrate, nafamostat better than heparin. And if you see direct thrombin inhibitors or other molecules, systemic bleeding tendency is high. There is no specific antidote also. And if such a situation occurs, we will always be preferred to use some drug which has an anticoagulant. So heparin becomes the third option.
So what percentage of your population you use heparin and citrate?
So at this point of time, madam, we are not using heparin for any of our patients. We are only using citrate-based CRRT.
When citrate is contraindicated?
When citrate is contraindicated, we are doing normal without heparin. We have that's what, madam. By the time we start CRRT, almost the patient condition will be in the downward trend. So our hands are tight and we cannot use heparin for that group of patients. But definitely, if the patient condition is moderately sick, and if they accept for CRRT, if no contraindication for heparin, we can start with heparin. But still in India, the setup is in such a way that we will be taking a lot of time to start CRRT also. But if we can start CRRT early, definitely the outcomes will be very, very better. And we can do with any modality of that. But if you want to prolong the main intention of the citrate is to prolong the circuit. So once this circuit has started, it can run continuously, and we can almost deliver proper renal replacement therapy. The main target of CRRT is to prevent further insult in the kidney. So if we tell some patients to go for dialysis, the first question they ask is whether I will be permanently on dialysis, when I am going to recover. So to answer that question, okay, this citrate or whatever CRRT that we are doing, it's a soft modality of dialysis, and it can definitely keep the kidney at rest, and it will allow the kidney to heal, and it will also prevent the further insults on the kidney also.
Thank you, Dr. Mahesh. Very informative lecture. What's your filter life without anticoagulation?
Without anticoagulation, filter life is almost 48 hours. That is average. But I have seen filters getting clotted in 6 hours also. But it depends upon the patient health status. Some patients, we think that the platelet count is low, the INR is high. But if they are in disseminated intravascular coagulation, rather than getting microclots in the body, we have seen the clots getting deposited in the filter, and the filter life is only 6 hours. But averagely, what we have seen is 36 to 48 hours we can run without anticoagulation.